Good evening, everybody. I'm sorry it's not really evening all over the world, but here in 4 o'clock p.m. here in Phoenix. Glad you guys could join me today. It's a topic we're going to talk about today that's kind of one I've been very interested in as I've gone through clinical practice in my career. CRPS is just one of those diagnoses that has historically been a massive head scratcher for me, really struggling to figure out what the heck is going on there. Paul Rock, nice to see you here with us, my friend. So that really struck a chord in me to say, well, why don't we look into this a little bit more? What is the research saying? I've been lucky to attend lectures from Adrian Lowe and Corey Zimney, and obviously everybody's listening to Lorimer's work on it, and just a lot of folks at the International Association for the Study of Pain. This year they did have Flavia Di Pietro's a researcher over in Australia who presented some work along with Flavia Mancini. And I'm blanking on the doctor from Cincinnati who's a big spinal cord researcher. But regardless, it really threw my brain for a loop just because it conflicted with what I had been taught and what I had thought I understood to be correct with CRPS as far as some of the sensory representations and things. James Stark, good to see you. So I wanted to share my presentation just a little bit on CRPS and some of the things. I actually went and tweaked it today based on some of the new research that we had. And my daughter, I apologize, just crying in the background. She's had a rough afternoon at daycare. So this presentation is quite new as far as updated with some research. I'm not by any means saying this is the most detailed CRPS presentation, but I just wanted to go over some of the key points because I think it is something, too, we see clinically more than we recognize. I think there are times that people are exhibiting CRPS and we may not know it. I know I have in the past had these people that have these extreme reactions after surgeries or after injuries. And maybe earlier in my career, I didn't really, what is going on? Maybe, they must be just a little bit off psychologically, or all the horrible things that we think when we don't understand pain and don't understand the complexities of it. So, I think there's a lot to be said about understanding some of the classification schemes and different things. So let's get into it a bit and see what we'll talk about here is CRPS. So this quote is one that I see everywhere as far as CRPS is a painful post-traumatic disorder that is incompletely understood and difficult to treat. How many of you guys who are watching, I know we only have a few of you here right now, but have seen CRPS patients? And if you have, easy or hard patients to treat? I would say they're probably the hardest, if not the hardest patient that we encounter in clinical practice. I mean, there's obviously complexity and difficulty, and everybody's unique, and all conditions are unique, but this is one of the harder conditions that I've experienced in my clinical past and present that really has been a struggle. And by any means, if anybody who teaches about CRPS tells you that they have a 100% success rate, then that's somebody I would probably walk away from, because they are probably not ascribing to science-based things and really, not the best. So anyway, CRPS1 is the thought of, and this used to be called reflex sympathetic dystrophy, causalgia and other terms, and I think CRPS is the more modern term with it, but no evidence of nerve injury, CRPS1, and then CRPS2, evidence of a nerve injury. I've a case that I saw a couple of years back that was a nerve injury was after a distal biceps rupture from a mason, a stone worker. They clipped unfortunately injured his musculocutaneous nerve and set off just a terrible pain situation in this gentleman's arm, and turned into a very messy thing because, of course, it was work comp, and we all know how lovely work comp is on helping somebody have an adaptive, view on their condition and put them in a good situation to heal, but unfortunately he didn't have a good outcome. So let's talk a little bit about the central and peripheral pathology in CRPS. And this is from 2016 from a Galvavia study where they kind of looked at CRPS and some of the interaction between the central and peripheral pathology. I'm not going to go into all this stuff with you guys, but the big thing I wanted to go with this slide is it's really complex. I mean, there's a lot of stuff going on with CRPS. We have psychological and neuroplastic mechanisms. So we have reorganization of the sensory cortex, which is interesting because I'm going to talk about that it may not be this S1 reorganization that we thought, or at least the smudging concept in the S1 at least in CRPS. has been called into question significantly, which again was just a big earth-shattering thing. Now, it's not to say cortical smudging doesn't happen, but in CRPS, at least in the S1, when people look strictly at the S1 area of the brain, which is your primary somatosensory cortex, they're not seeing what we thought we were seeing. So we'll talk about that as we go on. Definitely alterations in the motor part of the cortex. We see folks that have different motor dysfunctions and different things, dystonias and stuff around it, just weird kind of movement behaviors and kind of dystonia, like I said, that doesn't fit for your traditional injury or traditional kind of just musculoskeletal strain or sprain. Activation of glial cells. We know glial cells in the immune system much more important than we had thought previously. They really modulate that nervous system connectivity and sensitivity by really being a synaptic pruner and really strengthen synaptic connections or can dampen synaptic connections. And when the immune system ramps up with glial cell activity, that can definitely increase sensitivity, disinhibit things, connect things that normally should be inhibited, and disrupt some of these homuncular representations. Again, that's one that I'm still hashing out. I think science is still hashing out, thankfully, so I don't feel too done with that. We get disturbances in temperature and mechanical perception. We'll talk a little bit about cold and warm CRPS and some of the subtypes that exist in CRPS. We get spinal mechanisms. We get neurogenic inflammation, where there's this kind of antidromic flow from nerves into tissues, causing a lot of pro-inflammatory events to happen into tissues because these sensory nerves and nociceptive apparatus is really, I kind of term it, backfiring into the tissue and causing a lot of pro-inflammatory things happening, with maybe that tissue, of course, gone through a healing process. And that goes with some of the primary and secondary hyperalgesic responses. Of course, primary more from the nociceptive peripheral sensitivity, and secondary hyperalgesia more happening from the spinal cord nerves. Allodynic issues, sympathetic maintained pain when we have different stress systems and things involved, and sympathetic systems involved where they can start wiring into the pain experience as well. Dystonia and motor disturbances, like we'd already said. And then what do we see with people? We see people with just these red, swollen, sometimes, but it can vacillate red, then all of a sudden becomes cold, blotchy, hypoxic and acidosis. There's increased susceptibility to blood vessels and then trophic changes in the hair, skin, and nails. You see these folks with that kind of trophic changes in the skin and nails, which is some of those things we should be looking out for clinically to understand maybe this person does or does not have CRPS. Now, IASP came out with a criteria through kind of a meeting of the minds of the experts around the world. The citation comes up on the next slide here. But the Budapest criteria is kind of what we use and what you should use kind of clinically, and you can use this as a physiotherapist, chiropractor, or anybody, because these things, you got to be able to examine some of these things, and we'll talk about it. But these criteria talk about, number one, continuing pain, which is disproportionate to any inciting event. So we get folks who might be a wrist fracture or an ankle fracture, and man, this healing process isn't going where pain is nicely decreasing over time. They're showing this hypersensitivity, not even allowing load or any pressure or touch, allodynic, all these things that just doesn't look like it's proportional to what we would expect for it. Linda Crawford, Mark Butner, Mr. Halimi, Michelle, good to see you guys. Then the second part of this is the patient must report one symptom. So this is a patient report thing. So sensory, they might talk about hyperesthesia or increased sensory sensitivity in different areas of the body, or allodynic responses. Oftentimes I'll have patients say, I can't even put a bed sheet on my hand or my leg because of this sensitivity I'm having with it. Vasomotor, you'll see people who talk about, man, it feels like really hot, or sometimes people will talk about how it feels like just really cold, and they'll talk about skin color changes or skin color asymmetry. These are, again, patient reports. Pseudomotor edema and edema, so you'll see people talking about sweating issues, or they're clammy on one side, or they're just swollen on one side. And then lastly, motor and trophic changes, where you get decreased range of motion or motor dysfunction. And you can see I had a patient with a tremor in her arm, and it was interesting. She had I think it was some cysts or some things removed from her neck in the kind of scaling area, and I think they did something that set off an issue with the brachial plexus, but it set off this whole arm, shoulder CRPS reaction. She had tremor and different things, which was just something I didn't understand prior to, but it definitely struck me as a significant CRPS case, having had some of this information on board. And then obviously the hair, nail, and skin changes some folks might discuss with you as well. And then 3, the signs, and these are things we examine in the evaluation. So clinical or scientific of the following categories. So sensory, evidence of hyperalgesia to pinprick. So some of you guys may have your Greenfield, I can't remember the name of those little fibers that we use for sensory kind of pinprick, or just use a nice paper clip, dull and sharp side. And or allodynia to light touch, or superficial tissue stroking, and or deep somatic pressure or joint movement. So people are getting just severe pain and reactions to simple joint movement. Vasomotor, there's evidence of temperature asymmetry. Some folks that may see folks primarily in maybe a pain setting or a multidisciplinary pain setting who focus on CRPS might have some tools that you can use. There's things you can plug into your iPhone these days where you can do like a thermal scan of the hands and measure temperature and see if there's any asymmetries going on there. Pseudomotor, obviously edema is something we can measure. Sweating changes is something you can examine, of course, or sweating asymmetry. It's interesting, I've had folks where that CRPS extremity is just significantly more clammy, sweaty, and just different than the other extremity. And then things we normally measure as physiotherapists: decreased range of motion, motor dysfunction, again, that weakness, tremor, dystonia, and or those trophic changes that we spoke about earlier. And then lastly, there are no other diagnoses that's better explain the signs and symptoms. So that's the criteria that Hardin et al. In 2007. I'll link that study below here in the comments. Jamie Schwartz, good to see you. So that's a good batch of criteria that we can use clinically when we're starting to see people, because you will see people, and if you're definitely in the direct access setting, if you see folks a lot in a post-operative setting, especially if you work with orthopedic surgeons frequently, this is something that unfortunately happens to some of our post-operative patients, that they'll have these dramatic reactions after this. I think a lot of physicians, that is like the most dreaded thing that they hear from a therapist. I remember at the Mayo Clinic, I'd report back to some of the operative physicians of some of the signs that this patient's heading down and has all the signs of CRPS, and that what that means to the physician is this is going to be a bearer of a management. It's not going to follow that nice and neat healing where they have maybe a follow-up or two with the orthopod and life is all hunky-dory. This is going to be a long-term management scheme, and likely other disciplines are going to have to get involved. But thankfully there's healthcare systems like Mayo and others and clinicians out there who have a good understanding of this criteria. Now, Stephen Brule is probably one of the bigger researchers. If you just go on Google Scholar and look up his name with CRPS, you'll see quite a bit of literature that he's published on the subject with him and his research team and research colleagues. And they looked at evidence they did some fancy examinations of these folks. They took groups in these specialized settings that really focused on CRPS, and they looked at what are the signs that they show, and did these groups that kind of traditionally were discussed, that there's this warm and cold CRPS, and that was mainly something that was more anecdotally created because it was clinical patterns that clinicians were seeing over time, and they wanted to say, well, what if we evaluate this and really study these folks and see, is there that kind of thing present with folks? Is there this two groups, these subtypes that we've kind of discussed and kind of anecdotally created over time? Is there some validation with this more from a quantitative standpoint? And what they found with this group of folks with CRPS is that there was a definitive different groups of warm and CRPS. They found these groups average about 4.7 months for warm CRPS. They'd had the more warm, red, edema, sweaty, and had significant inflammatory scores that were present in these folks. So it was more when inflammation was significantly present in these folks. Then the other group becoming the cold CRPS folks. The interesting thing with the warm CRPS folks, to back up a little bit, is they transition over time where these inflammatory markers become much less prevalent, and it becomes more, of a, I guess, not as much of a pro-inflammatory issue, and becomes more towards that cold. So there is a transition that they see happening that often can be signified by less of these inflammatory markers, where our immune system isn't becoming as active and protective of that extremity. And these cold CRPS folks, they saw averaged about 20 months, cold, blue, less edema, and then less of those inflammatory scores that they saw with the folks in the warm CRPS. So again, that validated that there was thoughts that, hey, there are these two different groups out there, subtypes. Now, there's probably some argument that it's not a perfect subgroups, and there's definitely some nuance that probably lies between that, but there is that general thought that there is these two groups out there. One of the cooler things I've seen with some of these studies that I think is just fascinating, because you'll see folks with CRPS, like the really severe cases, and I can't say I've seen like super severe folks. I haven't worked in like multidisciplinary pain settings where a lot of these folks are being treated in different things, and I honestly don't think PT, at least where I've worked, is understood to be as much of a help for those folks. And again, I'm sure the batting average of therapists of having a perfectly successful treatment with a lot of these folks isn't maybe as good, but I think there's still a lot of things I think we can do with these patients, and we'll talk about it here as we go on. But this talked about spatial versus somatotopic processing. So whether our body is processing the space around us, or is it processing the surface area of your body and kind of having that organized map of our body in our head. And the interesting thing is that when they looked at folks, when they did these stimulus tests to these folks with CRPS, and they had these, when the hands were uncrossed, as far as when they stimulated, say the left hand had CRPS and the right hand did not, and they were required to stimulate the left or affected side 25 milliseconds earlier for the patient to perceive that to be simultaneous. So there was some sensory processing issues that required, and probably more because there was a lot of scrutiny going on to that affected hand, would be the thought, as far as your nervous system is really processing and scrutinizing what's going on with that affected hand, and not as much on the unaffected. But these folks needed to be stimulated earlier on the affected hand to be perceived simultaneous. The interesting thing is when these folks crossed it over, so all of a sudden the right hand crosses over to be in that left hand space, and the left hand crosses over to be in the right hand space. So these are the folks that are crossed over here, and they saw that now the stimuli needed to be delivered 18 milliseconds earlier on the unaffected side. So there is something about the space. So there's not, the hands are, the supposed affected hand is now on the other side, occupying the space of what was the unaffected side, and now all of a sudden, that unaffected side, being where the affected side used to be in that space, now needs to have the same kind of earlier stimulation for the body to be perceiving it as simultaneous. I hope I didn't confuse you guys with that, because this study's a little bit deep, but it just goes to show that there is a spatial processing issue, not just a somatotopic. Because if it was just simply on specific body parts and the skin and tissue, it shouldn't matter where that body part occupied in space, because it would just be the tissues being different areas of the tissue being stimulated. So that's just an interesting thing to think about, and I think that goes to a little bit about this neglect thing, where people start neglecting whole spatial parts of their body when it gets really severe with CRPS. You'll see pictures of folks who are completely looking away from their appendage, and they start developing some of this spatial neglect things, kind of like what you would see in a hemiplegic stroke. So it's just interesting and fascinating research, and I don't think we've really scratched, or I think we're only really scratching the surface of all the interesting changes and things that drive a lot of these changes with folks. But needless to say, we have to be aware of some of that spatial processing issues, and maybe use it to our advantage, or maybe there's things we can leverage with that clinically. I'm not sure at the moment, and I'm sure there's smart people that are working on it as we speak. One of the interesting treatments that were out there is this thing we call pain exposure physical therapy. So this is basically a program. I'm going to kind of really simplify it, and those of you folks who might look into this more deeply, don't get mad at me, because I'm not giving it as in detail as you like. But the pain exposure physical therapy is basically, they talk a little bit about pain education, where this pain is a false warning and you work function despite levels of pain, as far as you remove pain contingency, and you're kind of exposing people to movements and functional things. So it's kind of almost a little bit of a form of exposure-based therapy, but in this program, fear is kind of a predicating. They don't really go after fear as much, and it's kind of almost sometimes an exclusionary thing in this program. If you guys want more information on it, I'll definitely can send you some, and I'll link some of these articles. The interesting thing is when they compared this to conventional, which is just the standard biomedical way of looking at pain's a sign of dysfunction, you improve function while you control the pain, as far as it is very much pain contingent, as far as what you do in therapy and how you move and how you do is depending on pain levels and different things. And you can see 5 to 6 sessions here, compared to 15 to 20 on the other side. So that's a significant difference with folks. And the interesting thing with this study is it wasn't perfect. There was a lot of issues when they started looking at some of these levels. They looked at a impairment level sum score, and they looked at other visual analog scales, active range of motion, pain disability index, the SF-36, and other timed up and go tests. and there was a lot of people that switched, and the folks in the pain exposure physical therapy group actually got some of the conventional treatments. They didn't just not get medicated and do things, so they did have some of those things, and they listed out very detailed in the study. The intention to treat analysis, which is just basically if you take dropouts, but you take their values and you just push them forward into the analysis, you don't drop those folks out of the analysis, you keep them in the analysis. Really, it showed there was no significant group differences when they did an intention to treat analysis. So that's just a control for dropouts and to really make sure the data doesn't get skewed from people that just stayed in the study. Now, a per protocol analysis is when they look at the folks that actually stuck through the protocol. And we can imagine, and we see this clinically day in and day out, there are people that when we ask them to be exposed to pain, that is just something that is not in their current state of acceptance. They're not ready to just go after pain. Maybe they're in a state of, I need to have this fixed. I'm not going to expose myself to pain. Maybe my pain equals damage. Maybe they didn't really buy into the pain neuroscience education, or this pain is the false warning education thing that the folks in this study gave to them. But regardless, when they did look at folks that stuck through the protocol and went through it all, is there was a significant between group differences in these impairments level sum scores, the pain levels, active range of motion, all those different things. So folks that can stick it out, and that probably represents folks that maybe their narrative changed, and maybe they're maybe they were receptive to pain. And again, this is me speculating. I'm not exactly sure. I haven't talked to these people to know exactly what drove them to stay in the study and what was representative of them staying on protocol. But obviously there was some buy-in, or we met some sort of expectation, or maybe formed some therapeutic alliance with these patients to where they were on board with going through this exposure thing. Because for those of you that work with CRPS, this is a painful condition, and it is not fun for those folks to engage in pain. And I think a lot of pain education and different things, and really trying to meet the patient where they're at and see if they can start slowly working into some of those different thoughts and changing their narrative around their condition. But that's not easy work, especially if you're in situations where they've been biomedicalized and really clutching the narratives that aren't maybe as adaptive. So that's just an interesting study that looks at exposure-based treatments. So some interesting things, if we can get people maybe to buy into an exposure-based approach, that it might be a helpful approach for folks with CRPS. It's definitely not a perfect approach, but definitely one to maybe think about in your clinical practice. This looked at more of a true cognitive behavioral exposure approach versus treatment as usual. The nice thing about this study by Den Hollander and Lauren Mosley actually did a kind of a talk about this exposure in vivo and things with patients in this same journal article. I think it was 2016 of March in the Pain Journal, if you want to get into it. They did controlled things as far as they did 17 hours and 17 weeks of sessions. Obviously, there's more sessions with the treatment as usual group because of their 30 minutes versus an hour sessions. But they looked at, from the exposure group, cognitive behavioral therapy-based fear avoidance model. They reduced disability by lowering the levels of pain-related fear. So this is, again, some of these behavioral experiments, engaging in painful activities, having people confront their fearful beliefs. And they did use some different things like the FODA and other things, photos of activities of daily living, where they did a kind of fear hierarchy and had people work into a graded level of fearful activities to start taking more of a true exposure-based approach. And they kind of took a no pain, no gain approach in this study, as far as kind of pain isn't something we worry about. We work with or without it. It's not something that we're going to work contingent on. You're going to work based on functional activities that address your fear. Treatment as usual is your similar biomedical pain contingent ergonomic stuff. Increased control of pain to optimize coping with CRPS. With pain, no gain. So this is, again, kind of what we tend to do to folks, and kind of the cultural beliefs around pain. I think the dominant cultural beliefs, at least, that we should not function. Pain needs to be controlled. It needs to be medicated. It needs to be fixed before I engage in valued activities, before I engage in things in my life that are going to be give me value or give me meaning. And those are narratives we run up against every day that we work with and try to improve and change with some of our skillful dialogue and motivation interviewing and all that stuff. But anyway, outcomes measured pre-treatment, post-treatment, and 6 months out. They looked at lower extremity and upper extremity disability. They looked at a neuropathic pain scale, pain catastrophizing scale, BOTA, in the short form 36. They found that exposure-based therapies was superior to treatment as usual in reducing upper extremity disability from pre-treatment to post-treatment, and from pre-treatment to 6 months follow-up. So there were some long-term effects. Now, the one thing that, if you read Lauren Mosley's critique of this study, is treatment as usual is based on this pain contingent, traditional way of looking at it. And if you look at the clinical guidelines that should be driving treatment as usual, and we see this in so many conditions where treatment as usual that we see out there in the clinics in biomedicine still aren't reflecting clinical guidelines, because it takes a while for the folks to get on board with that. So that it's there. The treatment as usual in this study was not very representative of what ideal treatment as usual should be. But again, that's if we can figure out how to get all the healthcare to change behaviors and start treating more based on guidelines. I wouldn't be here with you. I'd probably be at the National Institute of Health, kind of driving big time change in the U.S. But that's a very challenging task that even the most smart people are trying to figure out. How do we change behavior treatment from, we're so worried about changing behaviors from our patient, but I think also from clinicians is a big challenge as well. James, I see you're asking me about sharing the paper. Definitely, I'll share the paper up there. Linda Crawford's talking about she's had some kids and adolescents who've had this type of treatment and made them much worse and fearful, tough, protocol. Yeah, I think we can't assume that everybody's on board for exposure-based therapy, and I think it takes a lot of skillful interaction and skillful work with this. I don't think we can just assume that it's a one-size-fits-all approach. There's a lot of things that we have to take into account, and again, we can't just shove patients into our desired treatment protocol. We have to really see where patients are at, where their fear levels are at, how much they're ready to engage, different things. But it was interesting. Oh, I forget her name. It's going to drive me nuts. She presented Simons, I think Laura Simons from, I believe, Stanford or somewhere out in California. She presented at the San Diego Pain Summit, but she did show some adolescents where she was doing some exposure therapy with her adolescent patients, and a lot of times using different things, music and distraction and different things, and having folks engage. But it was interesting to see that in an adolescent way some of this exposure-based treatment's being used successfully in that case. But Linda, you mentioned not as successful with what you've seen. So again, I don't think it's a one-size-fits-all for sure. Exposure was superior in reducing lower extremity disability from pre-treatment to 6-month follow-up, but not from pre-treatment to post-treatment. So it's interesting in that where immediately after treatment, not as much, but long-term, this exposure-based therapy improved in this study. And then all secondary outcomes significantly favored exposure treatment to post-treatment, as well as pre-treatment to 6-month follow-up, moderate levels of pain-related fear. I think I butchered that as far as bringing over some of that data from there. But the big thing is the secondary outcomes were significantly favored exposure-based treatments. So again, exposure-based things, I think, is a skill. We have Corey Blickenstaff on our team who does an amazing job of teaching that. I'm not sure how much he's done it in the CRPS population, but some of these exposure-based things can be helpful, again, for the right patient. Is it a one-size-fits-all? Absolutely not. We're going to talk about other treatments here in a second that are also very popular. And this one that is a Cochrane study that Neil O'Connell, our friend over in the UK, did with Benedict Wan, James McCauley, and others. Lorimer Mosley also on this study, a review. And of course, Cochrane Review is kind of the highest level of systematic reviews we're going to find out there. And they looked at GMI as part of that review. And you can see here that there was some significant, and again, 2 studies in 2004 and 2, so there's not a big breadth of information or studies out there to really draw upon, but some interesting, favoring of when we look at a 0 to 11 on a patient-specific functional scale, that we see that, 2, and honestly, my brain's blanking on what the MCID is on the patient-specific functional scale. I know people are probably shocked by that, but if anybody knows it off the top of their head, I'd love for you to just push it in the old chat bar there. But also looking at, so again, when you look at these for post-treatment results and then follow-ups 3 to 6 months, there's some interesting data, although it's weak. These studies had some weaknesses. It wasn't perfect data. But there is some encouraging signs that GMI might be an appropriate, useful intervention for CRPS, and it's definitely one that I use clinically for these patients and have found some benefit with. Now, the other thing that goes along with GMI, this talk will not go into the nuts and bolts of GMI. We have Marcos Lopez and Mark Powers on our team who are top-notch in that department, so I'm going to let them share their knowledge with you guys somewhere down the road. But there is some weak evidence that in CRPS that the order may matter. I think they did studies mostly in 2005 where they looked at having mirror therapy earlier on in the protocol versus, establishing motor imagery first and then going to mirror therapy, and there were significant differences there. So there is some thoughts, again, not strong, like written in stone, which nothing is written in stone. If anything, we should know by now that science is not written in stone. It's written in pencil and to be, adjusted over time as our knowledge base increases. But for now, I think we can be okay to say that the order does matter for some patients. But I don't think we can, again, ascribe that rule to everybody. And this is where my brain, and if for those of you guys who are on this group, when we did when I was at the International Association for the Study of Pain's talk, the conference in Boston, I went to this talk by Flavia Di Pietro and Flavia Mancini, and they talked about some of this stuff that we were kind of taught when I've really studied CRPS, and kind of when I went through some of the trainings and different things that I've gone through in workshops, that CRPS is this smudged map of your affected extremity in that S1 area. So they would say that the representation of your hand and your homunculus in your S1 area. And again, these studies talk about S1, so we have to recognize there's other areas of the brain that process that appendage more than just the S1 sensory representation. But these are studies. This is one that's kind of in press before publishing, that was released in Asafkov. And I don't know if I butchered your name. I'm sorry, my friend, if I did. But this is, again, Flavia Mancini put this out and looked at, they basically did some funky things with fMRI where they stimulated the fifth and first digit and then looked at, the geometry, size, and different things of the CRPS hands, the affected versus the unaffected hands. And their study demonstrated that the cortical area, location, and geometry of the S1 representation of the CRPS hand are comparable to those of the healthy hand. So this smudging or shrinking or expanding of the representation of that hand did not exist in this studies. Given that the S1 representations are largely preserved in CRPS patients, it is compelling to reconsider not only the cortical mechanisms that underlie the disorder, but also the rationale for interventions that aim to restore somatotopic representation. So when we're doing GMI with this theory and thought that we're redrawing maps, we're clearing up maps with CRPS patients, maybe the map, and I think if you think about it, representations of body parts does not just hang out in the S1. I mean, we have emotions about a body part, we have cognitions about the body part, we have thoughts about the body part, we have all kinds of things that are different areas of our brain, probably very complex neural networks that are representing that appendage that we can't. And I think we still look at this single causal way of looking at it, like we're going to find one area of the brain that's going to explain all these things, when a lot of the literature with neuromatrix and all these different things clearly show that there's not one area of the brain or one area that kind of tells the whole story when it's pain. So I don't think we need to freak out about this. I mean, I think we have to check ourselves and maybe think about the story we're telling when we do sensory discrimination and graph aesthesia training, and we do GMI with patients that we're not maybe redrawing the map in the S1, but maybe we're giving that body a better representation, less fear around it, maybe engaging with it so they develop more of instead of this adversarial relationship with their appendage, they're beginning to, like Butler will say, love your arm again and re-embody it again, and start to really, instead of having this battle of every interoceptive message that comes in from that appendage where you're just body's mounting defensive reactions on it, I've had patients say to me that it was almost like I had to make friends with my arm again, which is an interesting thing that's been sometimes a common thread that folks will say when they're, some of the patients, not everybody, that have said that to me, that I've heard multiple people say that without me cueing them to say that. So I do think there's a lot more than just the sensory S1 representation. But the other study here on the right is from Flavia Di Pietro. Both these ladies are amazing. I was able to reach out to these ladies through email, and very forthcoming. I'm going to see if I can get Flavia Di Pietro here on the group to just kind of talk about her research and talk about her thoughts on complex regional pain syndrome, because I think both these ladies are brilliant and great minds that we can all learn from. But again, her study looked again at the similar kind of mechanisms where they did fMRI scans, doing some funky neuroscience techniques where they're kind of doing stimulations of the fifth and first digit and then seeing how that represents geometry, size, and shape and different things. And the S1 representation of the healthy-handed patients was larger than that of control hands, but the S1 representation of the affected hand was no different to that than either hand in the control. So some of these things, again, damn science just has to keep on moving and keep on changing. That's why you can't drop an anchor in any belief system or anything. You have to keep flexible and be okay that our current methods are to be revised as research and science asks us to. So I'm going to leave you guys with this last slide. So what do we do? It doesn't mean that we throw away GMI. It has promise. Although the order seems to be important, that's still to be decided how rigidly we have to follow that order. And I think it's okay clinically if you try with the patient to not go that order and see if you have, you test that N=1 case study in front of you to see if in fact this research really fits with the patient in front of you. Again, with CRPS, it maybe other conditions that we still try to do GMI and different mirror-based things. It doesn't, and I have colleagues who do a lot more of mirror therapy and motor imagery in other areas outside of CRPS, and they seem to be the common thread I hear from Marcos Lopez, Mark Powers, and others, is that the order hasn't seemed to be as important in some other patients. But again, science we need to ask those questions clinically and then ask those questions from a research perspective and study them. That's where I think that beauty of the clinic and research kind of marrying each other, and social media and all this stuff, man, it helps us do it so much more quickly and hopefully more efficiently. But what do we need to do? We need to listen and understand the story. An interesting thing, I think I've shared this with you guys, and I apologize if I'm sharing some of you guys for the 40th time, but the biggest story that just resonates with me and probably will for the rest of my career was a woman in her early 40s who had just severe CRPS of hand and opposite foot, and was just having a heck of a time. And we were kind of as we were starting to do GMI and different things, we're talking about some of the pain education and some of the neuroscience behind it, trying to really scale it to stories that she understood, and she was on board and really digging it. She was doing her Recognize app, she was doing different things, and we talked a little bit about nervous system sensitivity and how stress and past experience can really modulate nervous system sensitivity, and what our life experiences are. If you live in a haunted house, your body's going to be probably more wired into fight or flight behaviors and activities and different things. And she just volunteered to me after having a discussion like that. She's, that's interesting because, when I was a kid, at my home, I was almost drowned twice by my stepfather in a bathtub. So that still almost makes me want to cry when I hear the story of, talk about the story, just because how horrible is that as a human being to be in the most safe area that you should be in your entire life? Home should be like the safest place that you can go for shelter, for food, for love, and you got people trying to kill you there. I mean, I can't even imagine that. I mean, obviously, I did not counsel her on that. I definitely discussed, have you talked to somebody about that? And she was actively going to counseling, but we did put some things together with her, and she was doing a lot better. I actually left the Mayo Clinic before her case left, but last I heard she was doing significantly better and starting to re-engage in some functional activities. But so you have to know what their cognitions, beliefs, fears around that limb are. What's their past experience? What do they think about it? This is, again, you have to understand the story that unique human being in front of you brings to it. Their unique perspective, their unique beliefs, their unique past experiences that may influence how much their body's fighting a battle and, having this adversarial relationship with that arm versus, the other spectrum of it. Exposure-based treatments have promise. Some thoughts would be, well, maybe we need to do GMI to where they can start engaging in pain. There are some people who skip GMI and go right to exposure-based things. Who's right, who's wrong? I don't know. I think science has to answer that for us, and some research has to answer that for us. But I do think, some exposure-based things, removing pain contingencies, almost getting in that behavioral pain treatment is something that has promise that we should be looking into. And as I stated earlier, pain is complex, and when we try to isolate it to an S1 change or one specific, neurochemical change in the body with some inflammatory marker, granted, this is what researchers need to do to ask an answerable question, because when you start expanding into complex neural networks and different things, the studies, and it's almost nearly impossible to do it. So I understand that, and that's a big thing that when I was at International Association for the Study of Pain's conference, is you see these researchers who have really narrowed down their questions to one specific biochemical neurotransmitter or brain pattern in one spot of the brain, and that's important to us to understand it, but we need to see the big picture, and humans are a big picture and a complex picture in a complex ecosystem that we need to understand. So I hope that you guys found this helpful. This is one of my passionate. I'm trying to build into a little bit more of a CRPS program at my current job. I've been there for a year, but I haven't been able to get that off the ground yet. I'd love to hear if anybody, you guys are doing some interesting things with CRPS, and maybe some of the strategies you use, share them with the group. Anything you can share that helps the group improve their understanding and treatment of folks, we're all on board. So with that said, I'm going to sign off from this. I hope all you in the U.S. who celebrate Thanksgiving have a wonderful Thanksgiving. I've worked out. I'm going to do a turkey trot tomorrow so I can just clear out as many calories as possible so I can indulge as much as I possibly can tomorrow evening. I hope you all have a wonderful time with your families. Those of you guys who do not celebrate Thanksgiving, have a wonderful rest of your day. I really appreciate the feedback I've been getting from a lot of you guys. If there's anything else we can share with you here in the group, another little teaser is I'm still in discussions with Peter O'Sullivan. Apparently he's busy. Apparently he does a few things besides just hang out waiting to talk to us. But we're hopefully narrowing down a talk with Peter in the very near future that'll be broadcast here live in the group. So keep your ears and eyes out for that. And then we'll be sharing more and more content as the weeks roll on. We'll be announcing that content week by week, and definitely tagging all you guys who want to be tagged in it. I hope you're enjoying it. And then on December 11th, we're having our big training to talk about the program we're rolling out that I think is going to really give folks a huge leg up to try to integrate this stuff instead of just reading blog posts and articles. How do you apply it to real human beings? So you guys have a great rest of your day. Have a good evening. Happy Thanksgiving to those of you all in the U.S., and we'll be talking to you guys later.